Well, I want to welcome everybody to our next session on peripheral neuropathy with Dr. Emily Splichal. So thank you, Emily, once again for being here. Coming to you with the Evidence-Based Fitness Academy and Naboso Technology, and Naboso being one of our sponsors, which we're really excited about. Um, if you have heard Emily speak before, you know that you're in for a real treat, and she's going to get deep into some of the science and practical applications. So we're really excited about that. I just want to make sure to remind everybody that these sessions are all being recorded, so you'll have access to them. So I encourage you to take notes, but also you'll be able to go back and rewatch and glean some more information from these sessions as well. If you've got questions that you want Emily to consider, you can put them in the chat box. That's fine, but I would recommend kind of holding on till closer to the end so your questions don't get lost. And then if we have time, we can go back and try to work through some of those. So without further ado, I'm going to turn it over to you, Emily.
Thank you so much. And thank you to everyone for hanging out with me for an hour to learn more about peripheral neuropathy. I did do this topic with FAI in a webinar format. So if you happened to have listened to that, know that this is going to be some additional information. So I always try to add on or do a new lit review or something for any topic that I ever speak about. So just as an FYI, if you ever see that, know that I try to make every single lecture I do just slightly new in some way. So we are going to be focusing on peripheral neuropathy. We are going to be focusing on both sensory and motor neuropathy. You may not come across motor neuropathy that often, but I still want to go into how it presents, because sometimes sensory neuropathy can eventually lead to motor presentations. We want to go into that. If you are not familiar with who I am in my background, I am a podiatrist, so I see a ton of neuropathy in my office. A lot of my patients in my current practice, even though I work very part-time as a clinician, a lot of the patients that I see now are chronic pain, chronic movement dysfunction, chronic movement disorders, which includes a lot of these neuropathies, even if that's not the primary diagnosis, like MS as an example. 25% of people with MS will get some sort of neuropathic presentation. So we want to make sure that we're thinking broad in this topic. And then my approach with those patients, with neuropathy patients, is much more beyond just the traditional podiatrist or neurologist. I give them vitamin supplementation recommendations. I encourage them to challenge the nervous system. I actually want them to be barefoot, where if you look at a lot of the neuropathy recommendations, they will say never ever take off your shoes. We'll go into why I think it's important. Of course, in a controlled environment, we're still being intelligent as far as how we do this. And then I wrote a book called Barefoot Strong, and the book Barefoot Strong, you can get it on Amazon. It's a quick read. It's, I think, $14, $15. And in that book, I go into peripheral neuropathy and how we can keep our nervous system young from a peripheral nervous system perspective. So we think of keeping the brain young. I spoke about that yesterday, and you have lectures around that. That's a lot of what Ryan speaks about. But we also want to think about keeping our nervous systems young and protected as we age from a peripheral perspective. And that's, like I said, going to be the focus today. Real quick, as I go back to here, if you do want to follow me on any of the social media platforms, these are my handles. Say hello. And I do a lot of posting of educational topics. If you want this PowerPoint, please email me, education@ebfafitness.com. I will make sure I mention that email address again at the end, and I will type it in the chat box as well at the end. But I do readily make my slides available. Thank you to FAI, very good friends of ours at EBFA and Naboso. Like I said, we do a lot of webinars, and super excited that FAI actually now carries the Barefoot Training Specialist certification. So if you've been wanting to get certified or you have been looking at it from a periphery, now it is available on the FAI platform. So please do look for that. I'm sure they will be sending out an email to you as well. And then Naboso, which is a company that I founded, I will be going into that product and how we help clients with neuropathy. So it's very appropriate for today's topic. So let's get started in the peripheral nervous system and peripheral nervous system disorders, which is what we're focusing on. Neuropathy is going to be one of those, but I do want to kind of keep our thought process a little bit broad. So now when it comes to the peripheral nervous system, different than the central nervous system, is that it's broken down into the somatic system, which is movement, and then the autonomic nervous system that we all know. So autonomic being sympathetic, parasympathetic, its association to the vagus nerve, the subconscious nervous system, that is part of your peripheral nervous system. We are going to be looking at both of these aspects of the peripheral nervous system and how they can present with neuropathy. So if you didn't know that there was such a thing as autonomic neuropathy, yes, there is, and we're going to go into that. A lot of diabetics actually get autonomic neuropathy, and we want to take that into consideration. So nerves that can potentially be affected by neuropathy are going to be your sensory nerves. These are the ones that are the most common. So most of the neuropathies that you see in your clients are going to be sensory based. This means that they have, decreased sensation to their feet. It might be one foot, it might be the distal aspect or where the toes are. It might be quite profound, where some diabetics will get a bilateral neuropathy that goes all the way up to the tibial plafond, or all the way up to the knee, and that's quite extensive if they can't feel knee down legs. And then of course motor, we'll be going into that, how that typically presents. There is a foot type that I often refer to as the neurological foot. This is going to be the client that has motor neuropathy. And oftentimes sensory neuropathy blending into a motor neuropathy can get a classic neurological foot. That is going to be a super high arch, and the digits are all buckled in. So very high arch, toes buckling in. You see all of the tendons on the top of the foot, and they start getting limited ankle dorsiflexion, and they almost start sickling their foot in. That's a classic neurological foot. So you will start to see that in probably some of your MS patients, some of the diabetics that have had neuropathy for a while. And then if you are familiar with Charcot-Marie Tooth, you could see that in that individual as well. And then, as I had mentioned, autonomic neuropathy is something that is can be affected as well. Okay, so let's start with peripheral neuropathy as it relates to sensory. So sensory neuropathy, sensory neuropathy. Of these, the most common sensory neuropathy that we can experience is of course going to be diabetic. Now, peripheral neuropathy, this is of course damage to our peripheral nerves. We would want to ask ourselves, what is the cause of that damage? Is it from inflammation? Is it from oxidative stress? Is it from toxicity? Is it a nutritional deficiency? So there's different reasons. Is it the body attacking itself? Yes, all of these are different causes of peripheral neuropathy. And then the presentation would be the individual gets weakness. They start to get digit contractions that I mentioned. They have numbness, they have pain. It of course affects motor patterns. So all of that is kind of that classic presentation of a peripheral neuropathy. Now there's different types. The most common types of sensory peripheral neuropathy are going to be traumatic related. Maybe they had a surgery and now they have a nerve that is entrapped. So you will actually see this if you have someone who's ever had an ankle fracture. So an ankle fracture where they actually have to go in and put in plates and they have to kind of derotate and stabilize the ankle. There's a lot of literature around having an entrapment. So the nerves as they come down into the foot and the ankle are very small, obviously because they're the furthest away from the spine, but because of the injury and the surgical incisions, there's a very high rate for nerve damage, traumatic nerve damage from the surgery, not from the fracture, from the surgery, and then nerve entrapment. And then those patients unfortunately present with a chronic neuropathy that is traumatic based, and they would present just like any of the other neuropathic patients. Diabetes is going to be the most common one. Here in the United States, we have over 17 million people that have diabetic neuropathy. So 17 million people have diabetic neuropathy, huge. Autoimmune diseases, so this is essentially inflammatory diseases, your body attacking itself for whatever reason. That's not the focus of the lecture today, but let's say you have RA, which is typically an inflammatory condition. The nerves can also get inflamed, and when they get inflamed, we start to get stickiness and kind of a misfiring pattern in those nerves. Nutritional is a big one. A lot of people will go towards B12 being a cause of that. However, other B vitamins can also be associated with that. There's a not common, but common among chronic alcoholism is that there's an alcohol-related neuropathy, both to the hands and the feet. You can see that. That would be a toxicity example. Chemotherapy, so chemo-induced neuropathy is a big one. I'm actually do a lot of work through neuropathy to bring awareness to this because it's a condition or a side effect of the chemotherapy that the oncologists unfortunately are not prioritizing because their goal is to reduce or help the patient become cancer-free. So again, their priority is a little bit different. Idiopathic, that's a diagnosis of elimination. So essentially they look for every other cause of neuropathy. They have no idea what it is. So it becomes a catch-all, which is idiopathic. And then HIV and AIDS, depending on your environment, you may or may not see a lot of patients or individuals with that. I did my residency and trained and live in New York City. So a lot of the type of patient that I learned on were HIV AIDS patients, and you just start to see different presentations with that type of neuropathy. So let's go into the most common neuropathy that you will see in your clients. This is going to be diabetic neuropathy. Now, what I do want to say about diabetic neuropathy is that a lot of individuals will actually show as the first symptom of their diabetes before they're even diagnosed is neuropathy. So your astuteness in this topic actually plays a really important role to potentially tell your client, you know, maybe it's worth going and getting a glucose test. Are you diabetic? Have you ever been tested for diabetes? Sounds like you're presenting with what might be the earliest signs and symptoms of diabetic neuropathy. So I encourage you to kind of know that you have that power as well. It's the patient's right to go to their primary doctor and say, I want to be tested for diabetes. So how does diabetic peripheral neuropathy present? Sensory neuropathy. This is what's called a stocking glove pattern. So it will always be bilateral. You will never have just your right foot in the toes, it tingles, and you think that you have diabetic neuropathy. It is always symmetrical bilateral. It's what's called a stocking glove pattern, which means it's going to start in the most distal aspect of the digits. Sometimes it's the fingers, but it's usually the toes. And then it's going to start to slowly creep up through the rest of the leg. You can see the pictures here really represent it well. Again, this can be some of the first presentation of that client with diabetes. Now, this is directly related to their blood sugar control. So you will have clients, if you start asking them, that do they notice that if their blood sugar is a little bit elevated, or if they eat something that they shouldn't eat, do they actually notice an effect in their neuropathy or in the tingling? And I will have patients that say, yes, when I eat the way that I should not, I eat, you know, a lot of bread, or I have, you know, something with high sugar, you know, about an hour later, I feel my toes are tingling. So they can actually notice that within their body, which is quite astute, but something that we want to notice as well. So when we look at the cause of diabetic neuropathy, this is going to be directly related to glucose, excess glucose. And then what happens to that excess glucose is that it starts to glycate, or it becomes oxidized as a free radical. And then that free radical is called an AGE, or an advanced glycation end body. You could just simply think that AGEs age the body, right? So we don't want to have high free radicals or high inflammation or high oxidative stress. I think that those are things that you, terms that you have heard of and are quite familiar with. You can think of diabetic neuropathy as directly related to that, okay? Now, why it attacks the nerves has to do with the blood vessels that supply the nerves. So if you're taking notes, I would actually kind of write down and say diabetic neuropathy is or equals microvascular disease. So this is a disease of the teeny tiny blood vessels that supply the nerves of your distal or the tips of your feet and the tips of your fingertips. So microvascular disease. This is different than macrovascular disease, which is heart disease, right? So when someone has hypertension or high cholesterol, those are more forms of macrovascular, okay? So now the glycation free radicals, AGEs, they attack collagen. Collagen lines the blood vessels, the tiniest blood vessels. Remember, this is microvascular, so it's a vascular disease. It's just presenting in the nervous system. Now, why your collagen gets attacked or is targeted when it comes to free radicals has to do that it is a protein that has a very long lifespan. So if something is around for a long period, it has the opportunity to be exposed to inflammation and oxidative stress. So it sits there for more opportunity, and that's why it's attacked, right? Versus a cell that is turned over frequently, if it gets damaged, whoop, it dies and it replaces itself quickly. So that's really where we're seeing microvascular disease. So let's take a look here real quick. So when you get collagen, which is the protein of your blood vessels, and it oxidizes, it equals stiffness. So you get increased vascular stiffness, okay? This also leads to an increase in the LDL particles. So this is also why you get high cholesterol and hypertension and other comorbidities. When you get increased oxidative stress, your nitric oxide also goes down. Nitric oxide is a natural vasodilator. So if you think of nitric oxide levels, sometimes people, bodybuilders or people when they exercise will take L-arginine, which is an amino acid that upregulates nitric oxide. So L-arginine, this is actually going to be a treatment for neuropathy. So L-arginine, it's an amino acid that stimulates nitric oxide. Now, nitric oxide in your body, it has a very short fast life. So when you uptick it, you have to utilize it right away, otherwise it goes down. So people who exercise and bodybuilders, they will actually take pre-workout pump supplements, just call it, right? And part of that pre-workout pump has L-arginine. And what it's doing is it's trying to increase vasodilation so you get more blood flow, so you can live stronger, more oxygen to your muscles, and then you get the classic pump that everyone likes after they work out. Okay, that's the way that people use it. Viagra, just as an example, is a nitric oxide upregulator. That's how it works. L-arginine is a natural Viagra. Just FYI, you're welcome. But I take L-arginine every morning because it's also an anti-aging supplement that is micro-neuroprotective. Here we go. Okay, that's your diabetic. Diabetic neuropathy is a microvascular disease directly related to oxidative stress and inflammation. Chemo-induced peripheral neuropathy. Chemo-induced peripheral neuropathy, this is going to affect potentially up to 70% or almost 70% of those that are undergoing chemotherapy. Now we have an increase in cancer diagnosis that is now 1 in 4 adults will experience or be diagnosed with cancer at some point during their adult period. A majority of those cancers do go on to go through radiation and chemotherapy. And if we have 70% that are undergoing chemotherapy will experience neuropathy, this is a pocket or a huge potential of clients that we need to understand neuropathy. Now with chemotherapy, this would be a form of toxicity. So it's a toxicity related chemoneuropathy. What it does is it causes the axon is essentially the extension from the nerve cell, and that axon starts to degenerate from the toxicity. So it's different than the diabetic neuropathy. Okay. Now, some of the risk factors that you could ask your clients is the type of chemotherapy they're actually receiving. So some of the chemotherapies specific to those with like breast cancer and prostate cancer, those chemotherapy drugs are a little bit more known to be higher toxicity to the peripheral nerves. So you can also screen it out or filter it out based off of the cancer diagnosis and the type of chemotherapy that they are receiving. Now, it's interesting that they're actually showing that you can take different vitamin supplementations that are neuroprotective when you're going through chemotherapy. There's a lot of neuroprotective supplements that I'm going to go into in a moment, but here this is a research study just showing one example, which is vitamin E. So if you take vitamin E at high doses when you're going through chemotherapy in that period, it is shown to decrease the nerve toxicity that is often associated with chemotherapy. Again, that's just one example of it, okay? Now, let's say you have a client and they have maybe diabetic, maybe chemo-induced, maybe they have neuropathic, maybe they have nutritional, whichever the sensory is. Now it gets into how they present, and this is important to understand. So patients or clients with neuropathy can present with either positive symptoms or negative symptoms, positive or negative, okay? Not meaning good or bad, that's not what I mean. It's a way that you can break it down. A positive symptom is going to be like an upregulation. This is going to be a painful sensation. It feels burning, radiating, sharp, like someone's splashing water on my foot. That it feels like, you know, all of a sudden there's a bug crawling on my foot. So these different sensations that are hard for them to describe sometimes, but it is the positive or the uptick of a sensation. Again, not always pain. It's not going to be just like someone stabbing me. It could be like bugs are crawling on my feet. That's positive. The negative symptom is a void of a symptom. This would be the numbness is primarily. So when I can't feel my feet, that's a void or a lack of a symptom. That's a negative, okay? Why I mention this is because medications address different symptoms. Most of the classic medications that we think of with neuropathy, Lyrica, also known as pregabalin, gabapentin, also known as Neurontin, duloxetine, and other antidepressants, capsaicin is a topical. These neuropathy medications block the positive symptom. So if you have a client that is on a neuropathy medication and they have no positive symptoms, only numbness or a negative symptom, and they're on it, I would ask, why are you on that medication? Did you ever have a painful symptom? If they didn't, why are you on that medication? Because these medications have a lot of side effects. And most of the side effects are going to be a drowsy, brain fog, disconnect that the patient then experiences or the client experiences, that a lot of them, it starts to kind of change their overall functionality. Sometimes it changes a little bit of the personality. This is some stuff that I spoke about in the pre-con that I did. So you want to not push them onto medications unless they really have to be on them. And now the other big thing, that if they are on medication and they still feel the symptoms, then you want to encourage them to make sure that they're on the right dose. So I find that probably half of the patients that I see are not on the appropriate dose of the medication, which means that they're on like half the dose that they should be, which means that they're sitting here struggling still with the painful neuropathy symptoms. They're on medication, they get the side effects of the medication, but they're not at the therapeutic dose, which is very frustrating. And I feel for these patients because it's not fair for them to still be in circles trying to deal with this diagnosis when all they had to do is upregulate or lift the dosage that they're taking, and then they would not have the symptoms. So just some conversation, food for thought in the back. Okay, so now aside from the medications, aside from a pharmaceutical prescription, What can these patients or clients be doing? There are vitamins that these clients can be taking. You can recommend them. They're in my book, Barefoot Strong. You can refer them to me and I'd be happy to go over these with them. So Medinex is an example of one. This is a prescription vitamin B complex. It's actually FDA approved for diabetic neuropathy. L-methylfolate is the methylated or the activated form of folic acid. Benfotiamine is the activated form of thiamine or vitamin B1. R-lipoic acid, this is a great antioxidant. It's also neuroprotective. Acetyl L-carnitine increases nerve growth factor, and then L-carnosine also upregulates nerve growth factor. So all of these are amazing at protecting the nerves. So if I have a patient that comes in with neuropathy, and let's say they have no painful symptoms, they just have numbness, I say, well, what are you doing to slow the progression of the diagnosis or the damage to your peripheral nerves? If you're just not doing anything and hopefully they don't get worse, right? No, we have to be proactive. So then I encourage them and I educate them on these different vitamins. These are going to be the dosages if you're curious. Again, if you want this PowerPoint, email me education@ebfafitness.com. But these are going to be the dosages that they can take. All of these amazing supplements are water soluble, so you can take them on an empty stomach. Okay, you can take all of them, you can try a couple of them, but these are my nerve protective supplements. For anyone who has any nerve presentation, I do recommend these. And there's more, but these are some of the big ones that I look at. Okay, so now let's look aside from the symptoms. We understand the symptoms. It's obviously going to, aside from the positive and the negative symptom, we know that they have decreased sensation to their feet. If you have decreased sensation to your feet, of course, you're going to have trouble balancing. People with diabetic neuropathy have a 15 times greater fall risk compared to someone their same age with diabetes, but without neuropathy. Just let that sit in for a minute. 15 times greater fall risk. And it's because they cannot feel their feet. They have a disruption in the Mechanoceptors in the bottom of the feet. They're getting a disruption in the proprioceptors in the joint capsule and the muscle tendons. So all of the different protective responses for these individuals starts to get compromised. Okay, so how can we work out safely with peripheral neuropathy? Can we? Absolutely, yes you can. Can you work out barefoot? Absolutely, yes you can, and yes you should. How can we progress these workouts? And is there a way that we can safely enhance their sensory stimulation to actually upregulate and challenge these peripheral nerves? So barefoot training with peripheral neuropathy, all types of neuropathy, can you? Yes, 100%. You are doing it in a clean, safe, controlled environment, which means they're coming into your studio, or if you are training them virtually, they have the area that they know is going to be their barefoot training zone, let's call it, yeah? They will look at their feet before and after, right? Look at their feet. Sometimes people with diabetes, because just as the disease progresses, if they have a hard time getting down, if they have a hard time looking at their feet, like they might not be able to do like a figure 4 and look at the bottom of their feet. Not everyone can do that, right? So if they virtually, either you check it or virtually just go like this, show me your feet, show me the bottom of your feet. Okay, looks good. No breaks in the skin. Okay, great. Okay. We want to focus on foot engagement and short foot, strengthening the feet. Now, just because you have a sensory neuropathy and you cannot feel your feet does not mean that the muscles don't work. So we want to still make sure that we are strengthening the feet in these clients. Short foot, release the feet, balance exercises. I'm not a big fan of doing towel crunches, but if that's what you want to do because it's easier for them to get it, do a towel crunch. Lift the toes, spread the toes, get them to connect to their foundation. Okay. And then another hack that I'll be going into some other ones is use the stimulation of the hand to upregulate their sensation of their feet. They're connected and they're similar to each other in our somatosensory cortex, which was yesterday's lecture. If you did not hear yesterday's lecture, you can listen to the recording. All right, so how can we enhance our workouts to increase sensory stimulation in the client with sensory neuropathy? This is a great way. They're walking on pebbles. Obviously, be very careful. They're outside. I would not do this outside with someone with neuropathy, sensory neuropathy, but they're doing some sort of trigger point release. If you had a pebble path in your facility, 100% you can do that. If it's clean, there's nothing sharp, right? You can absolutely do that. So in order to properly stimulate the peripheral nerves, we need to know what they're sensitive to, okay? So the sensitivity of the nerves in the bottom of the feet is going to be through what's called mechanoception. Just to clarify, there's other nerves, nociceptors, thermoceptors, proprioceptors, which are the joints, and then mechanoceptors, which are in the bottom of the foot and the palm of the hand. The one that we will focus on primarily around true barefoot stimulation is essentially tactile or mechanoception, okay? But you can still stimulate muscle spindles and GTOs. I focused on this yesterday in yesterday's lecture on the somatosensory cortex. How do you increase stimulation to the proprioceptors for your client with neuropathy? Same way with anyone else. Use a weighted vest. That stimulates proprioceptors. That helps them to build body awareness. Use wrist weights, ankle weights, right? So they feel something, they feel gravity a little bit more. Use kinesiology tape. If you go into water, water's a great way to help clients reconnect to their body in space. They just feel their body more. So you can use those creative ways. When it comes to stimulating the bottom of the foot, this is where we look at very specific nerves that are called mechanoceptors. These nerves are sensitive to texture, skin stretch, vibration, and we actually use these nerves much more so for balance and stability when we walk. I spoke about medial lateral sway and quiet stance. So when we stand in one place, that's called quiet stance. And the way that you assess someone's stability in quiet stance is through medial lateral sway. We maintain quiet stance and sway through, if you look here on the slide, your SA receptors. So your SA receptors are called slow adapting, and they respond to two things: texture, which is 2-point discrimination, and skin stretch. 2-point discrimination or texture is the foundation to Naboso technology and all of the products that we create. It is essentially SA1 Merkel disc 2-point discrimination products to improve balance, posture, and gait. That's really why I developed the company and all of the products. So the 2-point discrimination helps to tell the brain where the body is to maintain balance, posture, gait. The highest efficacy with our products at Naboso are those with neuropathy, those that have chronic neurological conditions. Those are our two big ones. And then, of course, anyone over age 65 or anyone who has had a concussion or some sort of brain or neuro insult. The skin stretch, this could be through kinesiology tape. This could be standing on like a rough surface or something that's going to adhere to the foot. So you create that skin stretch. Now when we shift to FA1, FA2, which are our fast nerves in the bottom of the foot, fast nerves, they're sensitive to vibration, okay? We encounter vibration every time we take a step. Your foot hits the ground, you feel vibrations. We use vibration to know how hard we're striking the ground, but we use vibration to maintain our balance when we walk. If we start to lose our ability to feel vibration because we have neuropathy, what does that do? That decreases our ability to know how hard we're striking the ground, which means now your client is a little bit more susceptible to stress fractures, top of foot pain, plantar fasciitis, but your client is also going to have compromised balance because they cannot feel vibration. Okay, so this is what we're looking at, how we can bring in sensory stimulation. This is the distribution of these nerves, so the different nerve receptors, that's where they sit in the bottom of the foot. And then this is how I like to stimulate them. I like to stimulate them through trigger point release. There's some research that shows just 5 minutes of trigger point release to the bottom of the foot, or almost like the pebble path that was a few slides up. That pebble path is kind of mimicking the trigger point release. Walk across the clean pebbles for a few minutes, wake up the foot, improve the balance. Yes, whole body vibration through power plate. I know they're a partner through FAI. I have a power plate in my office. I've actually written several courses for power plate. So power plate and whole body vibrations stimulates the nerves in the bottom of the feet, stimulates your entire fascial web, and helps to improve balance in our clients. And then finally, Naboso, of course, that is our 2-point discrimination mat and insoles to improve balance, posture, gait through SA1 Merkel disc. Okay, that's our sensory neuropathy, okay? Now, let's take a look at our motor neuropathy. So we have motor neuropathy and autonomic neuropathy, okay? And then if you guys have any questions, please start getting those ready because we're going to go over those soon. So now motor neuropathy is different. Motor neuropathies are not as common as sensory. Sensory is primarily what you will see with your clients. The most common motor neuropathy that we will encounter will be Charcot-Marie-Tooth. I'm sure that someone here in the audience has had a client with Charcot-Marie-Tooth. Okay? Charcot-Marie-Tooth, it is a genetic motor and sensory neuropathy that it is essentially attacking the peripheral nerves, so kind of genetic into along the lines of autoimmune to the motor and sensory nerves. It has a very classic presentation. So the lower leg, it's like a stork leg is what they call it. So they get a atrophy to the muscles of the lower leg. So it looks very straight and skinny into the foot. That's a classic presentation of someone who has CMT that they've had for a while. So it's progressed. The foot, just like this picture, do you see that this is starting to look like a neurological foot? I would actually see that the digits are pulling up even more. And then the foot pulls into a inverted position. So I'm gonna see if I can get this to work so I can show you for a moment what this presents as. It may or may not. Ooh, I had a beautiful video for you and I don't think it's gonna play. It's okay. I will describe it for you. So what you will actually see is someone with CMT with a motor neuropathy, they will actually, if you can see my hands, they're gonna walk on the edges of the feet, the outside edge of their feet, and they start to get this foot drop. So they're walking and they slap their foot on the ground, and then when they put their foot up, it's inverted and it's sickled. And that is due to the imbalance of the muscles of the lower leg. So they start to pull in, they start to lose ankle dorsiflexion. What this means is that their foot starts to become more rigid. So you see someone with CMT or long-standing sensory neuropathy that they're getting a neurological foot, you then tell yourself and write in your notes that their foot starts to become rigid, which means every time they hit the ground, they're not unlocking and decelerating the way that they need. So they are very much susceptible to stress fractures and plantar fasciitis. They're susceptible to ankle sprains because they're so sickled like this because of their condition. So a lot of the CMT patients that I see in my office will actually present with ankle sprains. Now, the way that you can start looking at these individuals is I try to not push them into orthotics. And this might be a little bit counter of what you've ever heard, or if you go to a podiatrist or you send them to a podiatrist, is that podiatrists like to throw them into orthotics to try to take a foot that is inverted like this and make it flat again. I don't like that approach because the foot is already so rigid, and now I'm putting a rigid orthotic under it, and then they're in a supportive shoe. So now they're just this big sensory disconnected block, and they just like walk around like a big block that they're moving around. That's not the way that I look at the foot or the way that I want these patients to move. I actually, my CMT patients, I will get them out of their orthotics. I will put them into minimal shoes. In the minimal shoe, 100% I put the Naboso insole, because remember, they're kind of slapping the ground. So if they're slapping the ground and they don't have any cushion, They again, yes, they can get stress fractures and top of foot pain and plantar fasciitis. So I'm trying to build natural movement connection to the ground, but they need that sensory reminder where their foot is, the kinesthetic awareness. And then we do exercises and drills to increase kinesthetic / foot awareness so they don't have to look at the floor. A lot of them, when they walk, watch people who walk who have neuropathy and they're all like this, right? They're looking at the floor because they can't feel the floor. So that's why I like the Naboso insoles for that as well. You can use what's called an Aso brace. This will actually stabilize the foot. So an Aso, it essentially locks the foot up so they can't sprain their ankle as easily. It is something that, depending on their activity, may actually be advantageous, right? It's a soft brace. Correct toes, so I get them into something to get their digits out of this contracture. I want them to lengthen them, so I get them into correct toes. An AFO if they have foot drop. A lot of people with CMT will eventually get a foot drop. Or if you have someone who has MS and they have foot drop, what I find is that a lot of people with mild to moderate foot drop don't want the AFO. They don't like it. Some of it is the emotional side of having an AFO. They either didn't want like a really bulky AFO that's plastic, like this big bulky piece of plastic on the bottom of your foot, up the back of your leg. I wouldn't want to wear that either. So there's a little bit of kind of this emotional stigma that's around it. It is very important to have an AFO though, because it's throwing off their entire total body mechanics if they are walking without one. There's some really good carbon fiber ones that are now on the market. Totally email me and reach out if you have a client and you're wanting to have this conversation of an AFO. You can look up the Noodle. It's a carbon fiber AFO. You can use that for these clients. They should be exercising in it. Doing daily release to the bottom of the foot, as well as doing this daily sensory stimulation and kinesthetic awareness. Now, when it comes to motor neuropathies, they start to become almost spastic. So when you have a hypertonic client, a hypertonic foot, hypertonic lower leg, or anywhere in the body that's hypertonic or spastic, is myofascial release or trigger point release is much more effective than stretching. So if you just try to do static stretching, you don't get as good an effect with actual hypertonicity or spasticity, such as that of what you see with CMT and MS, or with a brain injury or with dystonia or myoclonus or anything like that. You have to go into an actual trigger point release. This is also where power plate comes in, because the power plate whole body vibration is causing a neuroinhibition, which can be used for these clients as well. Okay, now let's go into improving balance. So I'm going to give you a few balance hacks that you can use when you're trying to improve balance in these clients, whether they have sensory or motor neuropathy. Your balance strategy or balance hacks are: one, using the eyes. Teach your client to use their eyes when they are trying to balance. When they're doing a balance exercise, try to stay focused on one spot. The more that they're taking in the entire room, the harder it is for them to balance. Now you can build in eye movement exercises that challenges balance. But if someone has such compromised balance that you need to get them to feel comfortable and confident, don't throw eye movement exercises on them right away, right? Just have them get used to focusing on one spot. And then a really good exercise that I like for initiating balance training and balance enhancement is it's called peripheral vision training. And what you do is you look at something that's in the distance. So I'm looking at the door to my office, which is maybe 25 yards away. I'm looking at the door and I'm going to stare at the handle of the door. But while I'm staring at the handle of the door, I'm going to start to notice what's in my periphery. Don't move your eyes. Just start to notice and start telling me or saying out loud, like, I'm looking here, I see a little tag on a box over here. I can see my phone is down here, right? So you have to challenge the peripheral vision, which is extremely important as we age, but in fall reduction. So it's peripheral vision training. There's more on that on YouTube and things like that, or I have some videos on our EBFA YouTube channel. So that's balance strategy 1. Again, real quick, if you're trying to challenge someone's balance, that's where you do eye movement exercises. It's going to throw off someone's balance, okay? Balance strategy 2 is to use the skin on your hands, particularly the fingertips. So by holding something, holding a pen, holding your phone. I have a textured ball that we're coming out with Naboso, not showing that yet, right? Textured ball, something that's going to stimulate the nerves of the hand. If you're standing, you could touch the chair, touch the wall. You don't have to hold on the chair. You could just lightly touch it, stimulate the nerves on the tips of the fingers, which are way more sensitive than the feet, and it will improve balance, okay? Balance strategy number 3 is not doing handstands, unless if you want to. It's actually using tension. So tension elsewhere in the body. This means that when you're standing, trying to do a balance exercise, engage your core. That's tension. Does that improve your balance? Push your toes into the floor and do short foot. Technically, that's creating tension. Do you feel better balance? If you have your hands, push your fingers together. Push your fingers, make a fist. If your arms are out to the side balancing, reach to the walls, right? So you're putting tension in your body to improve balance. And then your 4th and final balance hack is going to be to breathe. Breathe, breathe, breathe. Never, ever, ever hold your breath. Sometimes if you're throwing something challenging at your client from a balance perspective, they might actually be holding their breath and you don't even realize that. So you want to make sure that you are encouraging breath. I actually cue breath when I teach. So every time I have the client turn their head, I'm going to have them exhale. So I actually want to hear them. Similar to how you would cue when you come up out of a squat, I want you to exhale. Here it would be, you know, okay, inhale, now exhale, shh. Like I want to actually hear it so you know that they're still breathing. Okay, so let's go into our last type of neuropathy and then we'll answer any questions that you guys have. Last neuropathy that we see a lot in diabetes, but it can just happen in its own, is autonomic neuropathy. This is where you start to see the skin really dry. It changes the way that our clients sweat. It changes the coloration to the skin. It changes temperature regulation to the skin or to the extremity. So this foot over to the right looks like they definitely need to do some hydration. But that foot, that would be a foot that if I see it in my office, I know right away that they have autonomic neuropathy, okay? This has to do with the way that sweat glands and temperature and all of the cutaneous regulation is being controlled, okay? Now, a really quick example of a autonomic neuropathy would be, actually, let me go back real quick because this is peripheral focus, but I want to just reference systemic autonomic neuropathy. This is where you could see if a client does have autonomic neuropathy, not just for the foot, but if you are training them and you're training them and tracking their heart rate, and their heart rate isn't responding the way that you would typically predict or expect, that can be the result of the autonomic neuropathy. So if they have a hard time getting the heart rate up, if they kind of sit up quickly and they get like an orthostatic hypotension where their heart rate drops as soon as they stand up, a lot of that can be related to the autonomic neuropathies. And then total in general temperature regulation. If you are training your client in, I don't know, like 100 degrees in Arizona, and they can't sweat to regulate their temperature because of the autonomic neuropathy, you really want to make sure that you're watching them, because if I can sweat to regulate my temperature, but my client can't, and then they're starting to have some of these systemic changes, I don't want them to pass out or to actually start to get some complications from that, okay? So that's also where you could see some of the autonomic neuropathy. I'm going to go in and wrap up with one last type of autonomic neuropathy or peripheral neuropathy that you might see. This is complex regional pain syndrome. And you may just randomly have a client that has a history of it. It's also referred to as RSD. People, technically that's not a term that's used anymore in the medical community, but RSD or CRPS, complex regional pain syndrome. This is an autonomic neuropathy. This is really where the sympathetic nervous system gets a little bit excited and then it can't get controlled again. You typically see this with or after some sort of traumatic event. Let's look real quick at what it presents with, okay? So this would be the client that sprained their ankle and or fell and broke a bone in their foot or something like that. And then they were immobilized in a cam walker or crutches. And then they had this negative response or a heightened response to the immobilization. And now they're having severe pain, pain just like lightly touching the foot. They get this extreme extreme color changes. Do you see how the foot on the right foot is red? They get swelling that just happens randomly. They have, you know, weakness and guarding, and everything is just kind of thrown off with this foot ever since the ankle sprain or the fracture and the period that they were immobilized. So now they are dealing with this chronic peripheral nervous system presentation. Now, this is something that is often a response to trauma to the nerve, and then it's overly immobilized. So anytime I have a client or a patient that has goes through surgery, has a fracture, or even simply sprains an ankle, I'm very mild or less strict on my immobilization with patients, because I see so much RSD or CRPS in my office, not anything related to how I immobilize the patient, but they're seeing me after a prior immobilization or injury. And essentially what it does is, if you just allow the nervous system that opportunity to just sit in stasis, it freaks out. The autonomic nervous system freaks out. And oftentimes we have to reset the nervous system for them. So this is typically how they present. They will have what's called allodynia, so heightened pain. Something that should not be painful is painful. Even lightly touching the foot can be extremely painful for them. So it's pain out of proportion, or pain that doesn't match the actual stimulus. They get temperature asymmetry or these skin changes. That's vasomotor that I had mentioned, vaso meaning veins. The edema, so they get swelling or different sweating changes. One foot sweats where the other one doesn't. Decreased range of motion, they get weakness. Some people will get spasm or like a dystonia, and then others will get tremor. They get trophic. Trophic means kind of skin, so they get super dry skin on it, or the skin is sloughing off. So these are the presentations of what you will see in these individuals. It is something that has very heavy emotional influence on them, because they essentially take a boot off one day and then they're presented with something that is chronic, with a lot of medical unknown within this category. So there's a lot of medical professionals that just don't know how to treat it, which is quite unfortunate for them. So if you have a client that happens to have this, or you're just kind of curious to learn more about it, is you have to stop immobilizing them right away. Someone should never be in a boot 24/7, on their couch, in their bed, in the boot. If you're not weight bearing, get the boot off. You don't have to be just stuck in stasis. You need to get some of that fluidity to the nerves and to the lymphatic system and to the circulation. So for individuals who have this, I do a lot of lymphatic massages. I do dry brushing for them. I will do a nerve block to try to reset their nervous system. I get them into very aggressive mobilization. This is after their fracture healed, after the ankle sprain healed. So all we're dealing with is a chronic peripheral nervous system issue here. I'm very aggressive in my mobilization for these patients. And it's typically past the point of, you know, it's like a full-time job getting them out of a CRPS presentation. So again, if you happen to see that, or you're just thinking on the back of your mind, just think of aggressive immobilization is never good for the nervous system. And you as a movement specialist can just be the bird on your client's shoulder saying like, are you sure that that's appropriate? You know, do you want to, you know, get a second opinion if you should be in a boot for 4 months? Don't ever be in a boot for 4 months, okay? Because we don't want the nervous system to get thrown off like that. So let's go into a quick recap while you guys are thinking about some of your questions that you might have. When it comes to the peripheral nervous system, we want to think of the potential insults or presentations that we can see. It's either going to be sensory, motor, or autonomic. Majority of what you're going to see is sensory. When it's sensory, it's going to be either diabetic, chemo, idiopathic, nutritional, or traumatic. Those are most common. Or it could be the sequelae of something else like MS, okay? And with those, you want to understand the symptoms that your client is presenting with. Is it positive? Is it negative? And then what are they doing to regulate it? Can you guide them and give them recommendations around medications, which is positive symptoms, or vitamins? And then you specifically as a movement specialist want to be challenging their nervous system, still get them stimulated with texture, use the Novoso products, get on power plate, have them walking across pebbles, have them release their feet, have them get barefoot stimulation as part of their workout. Because with the nervous system, what you don't use, you lose. So you want to challenge the nervous system that is plastic, okay? You also want to be thinking about getting mobility, trigger point release over stretching because of any hypertonicity or spasticity. You want to address that. Get the digits in a good alignment. I always recommend correct toes to individuals. If you can, trying to get them into a more minimal environment, still build kinesthetic awareness, but get them more into a minimal environment so they're not this static block that is just moving with their body. It's going to create a lot of fall risk. And then you want to think of your balance hacks. Eyes, skin on the fingertips, tension in the body, and then continuing to breathe. And then look at any of the other additional information that I have on dual tasking. A lot of the lectures that you're going to hear here, dual tasking, brain games, eye movement exercises, vestibular training, all of the stuff that you learn in every other lecture through this incredible summit. But you just want to come in with this understanding or this undertone of understanding the presentation of peripheral neuropathy. Okay, now as you think of those questions, please don't forget that Novoso, we are offering a discount for everyone at FAS. It is 25% off through the end of June. This is on all of the products, insoles, mats, our material. You can buy our material and, you know, put it on any sort of surface. We actually sell Power Plate Novoso mats. We partnered with Power Plate, and we have mats, Novoso mats with adhesive on the back that are designed for the Pro 5 and the personal Power Plate. So that's something great as well if you want to combine and double up these. We have Novoso wobble boards. So if you do any sort of wobble board training, it has the Novoso material on it. So we've got some great ways to help you. And then as I had mentioned in the beginning, super excited that we offer the Barefoot Training Specialist certification through FAI now. So please head to their website after the summit and check it out, how you can sign up for our certification in association with FAI. Thank you guys so much, and I will take any questions that you have. There are possibly a few in